Dear colleagues, I have the opportunity to present myself. I am Professor Dr. Saeed Abdelaziz, Professor of Cardiothoracic Surgery in Cairo University. It was supposed that we do the second annual meeting of the Aortic Root Master course in the next November, but for the circumstances, and we know all of us, the COVID-19 pandemic that has postponed everything, not here in Egypt, probably all over the world. So we have this opportunity to present some of our courses online. Like we got this idea to have a live webinar for the some of the courses in the aortic root, and this is the first one, and will be not be the last one, I hope so. So we choose that we have two courses today, or two presentations: the intramural hematoma and the penetrating aortic ulcer. This is one, and the second one is how to do TIVAR. This is the second one. So we'll start with the first one, is the management of intramural hematoma and penetrating ulcer. We all know that the aortic intramural hematoma was first described in 1920 as a dissection without intimal tear. The incidence of this, according to the IRAD registry, it is about 12 to 23% of all aortic diseases. The risk factors: the old age, hypertension, atherosclerosis, smoking. For the intramural hematoma, it is a circular or crescentic thickening more than 5 millimeters of the aortic wall in the absence of detectable blood flow in it. What we call it is a disease of the media. Like we see here, there is an atheroma in the media, and there is a crack, and then the blood goes out, and this what happened to the intramural hematoma. Intramural hematoma type A, which involves the ascending aorta, and it may be type 2 or type B, which involves the descending aorta. Like here, this is the surgical case that we have the hematoma inside the adventitia, and here it is more than 5 millimeters around the ascending aorta and part of the arch and the descending, and this is the cause of the hematoma. Intramural hematoma type B, which involves the descending thoracic aorta, as I say. Here, the ascending aorta is not involved, but the descending aorta, there is a hematoma around the descending thoracic aorta. What about the penetrating ulcer? The penetrating aortic ulcer is a chronic aortic condition defined by an ulcer-like disruption of the intima maturating within the aortic ligament. There is little evidence about the incidence of penetrating aortic ulcer, although its rate about 2.3% to 7% in symptomatic patients. The penetrating aortic ulcer, it describes a condition which ulceration of an atherosclerotic lesion penetrating the internal elastic lamina of the media. What we call is the disease of the intima. So there is a differentiation between the intramural hematoma. Intramural hematoma is the disease of the media, but this is for the penetrating aortic ulcer is the disease of the intima. And here we look, this is a disease of the intima, then crack, and then the hematoma. The penetrating aortic ulcer may involve the ascending aorta, as we see here. It may involve the descending thoracic aorta as it's here, or may involve the aortic arch as this here. This is another CT scan of penetrating aortic ulcer. It's here, and this is another one, and this is another one. What about the prognosis of the penetrating aortic ulcer and intramural hematoma? Let us see. For the intramural hematoma, if it is involving the ascending aorta, it is a lethal condition and is an indication for urgent surgery because of the risk of tamponade, rupture, or compression of the coronary arteries. And usually we treat the intramural hematoma involving the ascending aorta as a type A dissection that needs to be operated upon as soon as possible. For intramural hematoma alone, the best predictor for intramural hematoma regression without complications is a normal aortic diameter. If we have a patient with an intramural hematoma and its aortic diameter is not enlarged, so that this is a good prediction. 35% of patients will show regression. 16 to 47% of patients will progress to the development of aortic dissection, full-blown picture of aortic dissection, and 20 to 50%, 45% will develop an aortic rupture. Others say that 68% of intramural hematoma patients for 4 years, 20% of them will develop fusiform aneurysm, 8% saccular aneurysm, and 25% with pseudoaneurysm. What about intramural hematoma and the penetrating ulcer? If there is a combination of both. The intramural hematoma and the penetrating aortic ulcer has a progressive disastrous course, especially if present in the ascending aorta, because you have a penetrating ulcer, a hematoma that usually goes to rupture or tamponade. Many literature say that the high risk features that indicate that type B intramural hematoma is a complicated one. We have many risk factors: the age, the initial aortic diameter, mean growth of the aortic diameter, wall thickness, pleural effusion, aortic ulcer, and ulcer-like projection. So if we have at the age above 70, this is a risk factor. Initial aortic diameter more than 45, this is another risk factor. The growth rate, if it is more than 5 millimeter per year, is a risk factor. Wall thickness and presence of effusion and the presence of ulcer. For the prognosis of the penetrating aortic ulcer, in penetrating aortic ulcer with pseudoaneurysm formation, it occurs in 15 to 50% of patients. Risk of rupture may be related to ulcer diameter, which is more than 20 millimeters, or an ulcer depth. Its depth is more than 20 millimeters. Others say that the prognosis of penetrating aortic ulcer is also associated with bad risk if there is a pleural effusion, if it is associated with intramural hematoma, or if its depth is more than 10 millimeters. So what is the plan if we have a patient with an intramural hematoma or a penetrating ulcer? Let us start with the intramural hematoma. Intramural hematoma type A, which involves the ascending aorta, is always surgical intervention. This is why, because of the risk of rupture, risk of cardiac tamponade, risk of coronary ostial occlusion or compression. Here, as we see that, this is a surgical view of a patient with an intramural hematoma of the ascending aorta. And this is after surgery. We replaced the ascending aorta and we reimplanted the right coronary artery with a tube graft, separate tube graft. What about the type B intramural hematoma? There is always, first we start with the medical treatment, beta blockers and control blood pressure, and the mean mortality was calculated to be about 3.5%, but if we have an intramural hematoma in the type B with complication like diameter more than 45 millimeter, or if it's associated with an ulcer, or if it is associated with pleural effusion. Here we have the patients with type B treated open surgery when medical treatment failed, or if it is progressed to dissection or aneurysm formation or rupture. But the mortality in the surgical treatment of intramural hematoma type B, it is about 16% in the acute phase. In the chronic, it's about 23%. The endovascular management of intramural hematoma type B, it is always indicated in symptomatic and complicated patients due to the risk of rupture also, or dissection or aneurysm formation. Like here we have, this is a stent that we have put, and this is the cut section after the stent. We have here disappearance of the whole hematoma around the stent. The mortality rate in patients treated with TIVAR in acute phase is about 4%, and in the chronic is 7.5%. Definitely the mortality rate is less than the treatment of the surgical way in intramural hematoma type B. So many literatures tell that TIVAR for intramural hematoma can be performed safely and was effective and at relieving presenting symptoms in most patients. CT scan analysis demonstrated that significant normalization in all aortic measurements. However, the TIVAR, or the endovascular management of intramural hematoma type B, it is not always almost safe. There is endoleaks, lesions of the intimal layer at the ends of the device are most important complication and frequently necessitates reintervention. We see this. This is a patient that treated with an with a stent, and as we see here at the end of the stent there is a tear that causes an endoleak, and later on the patients came with an endoleak with aneurysmal formation. So to summarize, an intramural hematoma, if it is type A or type B, first line of treatment is always surgical in type A intramural hematoma, and if complicated type A or type B, in the non-complicated case we goes to medical treatment, and if complicated with a pleural effusion, with rupture, or with increase in the diameter, so in the complications we do either endovascular treatment or surgical intervention. What about the medical cases? We follow the medical cases, and if the follow-up shows that presence of complication, we shift to the endovascular treatment or the surgical management. This is for the intramural hematoma. What about the penetrating aortic ulcer? In the absence of randomized controlled trials, the level evidence in the treatment of penetrating aortic ulcer is always low, level C. The recommendations for treatment are mostly based on case series studies and expert opinion. It depends on the experience of the operator. Many authors reported satisfactory results with a conservative management of penetrating ulcers. However, most authors suggested that surgical intervention is indicated owing to a possible malignant course, which is rupture or cardiac tamponade in most cases. The mortality is about 15%. Here the surgical management of penetrating aortic ulcer in the descending aorta, like this, we do an interposition graft, and this is its picture in the surgical view. But this entails that we have to do left thoracotomy, single lung ventilation, systemic heparinization, cross clamping, and left heart bypass or complete heart bypass. What about the TIVAR, which is favorable in the treatment of penetrating aortic ulcers? It's commonly observed as a segmental localized wall lesion. It is an ideal target for endovascular stenting. Here, like this is a localized lesion in the descending thoracic aorta, so this is a good target for endovascular. Here, this is a case with a complication of pleural effusion and penetrating ulcer and treated with stent graft. Also, there is a features that in the penetrating ulcer that make it a high risk, that like rupture, like presence of pleural effusion, and like increase in the diameter. So to summarize the management, type A penetrating ulcer is also always surgical intervention. Sometimes it is an endovascular in specific cases. If it is non-complicated, so medical treatment. If it is complicated, it is endovascular treatment or surgical intervention. And if the complicated cases during the follow-up turn it to a complicated cases, so we will shift to the endovascular treatment and surgical treatment. So this is for the penetrating ulcer, and if we put a penetrating ulcer and intramural hematoma, we will find them identical except for the endovascular in some cases in the ascending aorta. To conclude, the intramural hematoma and the penetrating aortic ulcer are uncommon but potentially lethal aortic pathologies. Although intramural hematoma originate in an acute mode, penetrating aortic ulcer is a chronic disease, and that can develop rapidly, both with unpredictable natural course. The endovascular repair has become the first option in the treatment of complicated type B aortic hematoma and penetrating aortic ulcers, mainly when the lesions are localized. Surgical treatment is also indicated in most of type A intramural hematoma and penetrating ulcers. Surgical treatment is also indicated when endovascular solutions is not valid. Close follow-up for all patients by CT scan is mandatory. Thank you very much. My colleagues, we give the first presentation about the intramural hematoma and the penetrating aortic ulcer. So I will give you a 5-minute break that we can gather your questions, and then I will respond by answering these questions in the next 10 minutes. And after that, we will start the next presentation about the TIVAR, how to do it. أهلا بكم مرة تانية. Hi again for the people that cannot understand Arabic. And I have some questions I received, about 4 or 5 questions. Most of them are speaking about the hematoma in the arch. I will answer one question and then leave the other questions to the end of the this webinar session, because the second presentation is about the TIVAR and how to do it, and it is connected or related to the our presentation, the first one. The question that I will answer is the medical treatment in the uncomplicated cases of penetrating ulcer or hematoma. The medical treatment is simply to control the blood pressure, give beta blockers, and do follow-up CT scan in the first في acute case every 3 or 4 days, first week or second week, and then if the patient is stable after 2 weeks, then we can repeat the CT scan after 1 month. Nothing else for the medical treatment except just giving a beta blocker and controlling the blood pressure. Now we will shift to the second presentation about the TIVAR, how to do it. All of you know that the morbidity and mortality associated with conventional surgical repair of the descending thoracic aorta have driven the medical research to discover alternative techniques for treatment. In 1991, Barudi and Balmas placed the first human endovascular graft in the abdominal aorta. The indications for stent grafts and for the treatment of aortic diseases, the main goal of the stent is to cover an entry tear or exclude an aneurysm from the circulation. Many indications, all you know that thoracic aneurysm, leaking aneurysm, aortic ulcers, like penetrating ulcer, aortic dissection, type B, traumatic dissection, as in accidents, pseudoaneurysm, or aortobronchial fistula, or aortoesophageal fistula. Let us take it one by one. These thoracic aneurysms, like that, here we have descending thoracic, big descending thoracic aneurysm. Here another one, a huge descending thoracic aneurysm with intramural thrombus. This is another one, but this is a localized aneurysm. We cannot call this as a penetrating ulcer because this is a true aneurysm. And this is another one. Here we can call this an aortic ulcer, like I presented in the first presentation. It is one of the indication and of the TIVAR in the treatment of descending thoracic aorta or aortic diseases. This is a penetrating aortic ulcer in the descending aorta. We call it penetrating aortic ulcer type B. The leaking aneurysm, this is another indication. Here, this is a dissection in the descending thoracic aorta, but here we have pleural effusion. And this is another one, a huge aneurysm with chronic dissection, and there is a pleural effusion also. This is another case of type B dissection. Traumatic rupture, which is usually in car accidents or blunt trauma to the chest. It is a localized disruption of the intima at the isthmus of the aorta, just distal to the left subclavian artery. This patient, this is a 3D view, and this is the cut section view, and this is the sagittal view. This is the same patient. All of this are the same patient. What about how to do the TIVAR? First of all, the selection of the case. How to select the case that we are going to do a TIVAR for him. The case selection depends on many factors. The length and the diameter of the proximal and distal necks. At least we need 15 millimeter or more for better fixation and to reduce the possibility of migration and endoleak, which we call the landing zone. Here we have this is type B dissection, and here it is just distal to the subclavian artery. So we have this distance from the carotid to the subclavian artery is very narrow. So this is not a good landing zone. This is, on the contrary, a case of localized aneurysm, but we have a very long landing zone. This is a good candidate for a TIVAR as a landing zone. Other factor for the case selection is the presence of calcium or thrombus. the presence of heavy calcification or thrombus. This is not a good thing, because this leads to an endo leak and predisposed to migration also. Here, this is a lot of calcium at the landing zone. And other factor is the angulation. Presence of many angulation and tortuosity in the descending thoracic aorta. This is one of the obstacles in TVAR, and it might preventing good deployment of the thoracic stent as we like. Here we see that this is an angle at the diaphragm, and this is an angle at the mid-thoracic aorta, and this is an angle just before the arch. See, this angle is is an acute angle. Other factor in case selection is the axis where we are going to introduce our stent. The iliac and the femoral arteries axis, it should be more than 8 millimeter in diameter, and also should be not calcified. Here, look at this CT scan, a heavily calcified femoral arteries and iliacs and inferior infrarenal descending aorta. Other factor is the where is the disease? Where are we going to cover or exclude the aneurysm? It is in the abdominal, and in the thoracic, in the thoraco-abdominal, in the arch. Its location depends, and according the TVAR is good or not. Here, ascending aorta and arch are not suitable for endovascular stenting yet, but now there is a fenestrated grafts or the branched grafts for the arch, but not fit for all cases. So thus we have to say that endovascular stenting is not yet the standard in the arch cases. The thoracic aneurysm distal to the left subclavian artery and proximal to the celiac artery, those are the best chance for endovascular repair. You see this is not a candidate at all for thoracic stenting. The standard thoracic stenting, we can do that with the fenestrated grafts and 4 branched grafts for the celiac and the mesenteric and renal arteries, but this is a sophisticated case. I am speaking about the simple standard stent graft. And this is ascending on the arch. This is also not a candidate for stenting. The device, we have many devices in the market: Medtronic, Zenith, Bolton, Gore, Jotic, and others. These are some pictures of the devices. Here is Bolton, this is Valiant Medtronic, this is Cook, and this is a customized grafts with a scallop or with a free flow edge or without bare metal stent. So the decision is to do a stent to graft. So this is procedure requirement to do this. First of all, this is a multidisciplinary team. Multidisciplinary team has combined the procedural experience with femoral cut down, so you have to know how to do cut down, or a vascular surgeon can do cut down for you. Live fluoroscopic angiographic imaging interpretation, a radiologist should be with you, or a technician that can understand the tools and how to deal with the angiocath. Embolization, non-selective and selective catheterization. This is requires the wire skilled, and this is also for the cardiologists. Sneric techniques, ultrasound, and the use of contrast material. So where to do the stent grafts? Usually in a hybrid suite. An operating room supplied with a cath lab. But here in Egypt we don't have the hybrid room, but We can do it in the cath lab. There are certain standard equipments that we need to do a stent graft. First of all, fluoroscopic with digital angiography and high resolution fluoroscopic imaging and the ability to record and recall all images. Secondly, guide wires, catheters, pigtails and multipurpose catheters, introduction sheaths, 6 or 5 Frenches, sterile silicone lubricant material, radio opaque contrast, injection, the injector. These mainly the tools that we need in the cath lab to do a stent. So you have to be familiar with this, and you got this in your minds that you can gather everything and your needs to do. Supplementary equipment like snare, not all cases that we need snare, but we might need it in some cases. Balloons, dilators, sterile markers, IVUS, and etc. This is a small video that show you how we can do simply the stentograph. First, we introduce the wire like here. Then above the wire, we introduce the stent. Then we just give the stent away from the sheath. This is not yet deployed it. And then we deploy the first stent that we call it release the capture. After releasing the capture, that means the stent is fully deployed. In that video, we need another stent because this is a landing zone in the proximal part, but we have here still, we need a landing zone down in the descending part, so we put another stent. So we excluded from here the landing zone down and landing zone above. We excluded this aneurysm. To do a TEVAR, we need first to expose the access, which we call cut down on the femoral artery. And all of you as surgeons, you know how to do to expose the femoral artery, and as I told you, it should be not less than 8 millimeter diameter and without calcification. What about the sizing? This is a very good or very important to choose the type of the stent and to choose the size of the stent. Sizing is very important. Here, this is a short video also to show you how to use your computer to size and choose which stent size. Here, we increase the picture, and then we put the axis on the long axis of the arch, as we see here. And this is a good landing zone. We will now measure how to measure this landing zone. This is the proximal landing zone. We put the axis along the arch, so we got it here, a round circle, and this we measure this round circle here. And that picture, it measures about 4 centimeter or 40 millimeter. After then, we go to measure the distal landing zone. We measure the proximal landing zone, then we go down to measure the distal landing zone. We will move this here, yes, like that, and put the axis along the axis of the aorta, so we can get a circle to measure properly the size of the stent. Here we will size this circle. Yes, now it is a good circle. We will measure this. It is 26 by 30, so its average is 28. So we have a proximal landing zone 40 and distal landing zone about 28 or 30. So in that patient we can use a stent 40 or 42 down on 34. Also, things that we need to measure is the length. So we will use one stent or two stents, because the maximum length of a stent in the companies is 23 and 25. This is one stent, but if it is not available and we need to cover about 30 centimeters of the descending thoracic aorta, so we need to have two stents. We can put two stents inside each other with a good landing zone between them. So we have to measure the length. In that patient on the video, I think we will need to cover from the carotid artery till the descending thoracic aorta just above the diaphragm. So I think we will need to cover more than 30 centimeters. And this is sizing. It comes with practice. You cannot learn it from a video, but we have to practice and have CT scans and put it on the computer and do measurements, and you can measure wrongly and then correct yourself and so on. Then we will move to the next step. Is we choose the stent and what type and which type of stent, and will we use one stent or two stents. So preparation is to prepare the cut down, and then this is an introduction sheath, what we call the use femoral sheath. Over it we will introduce the wires, and this is the picture of the stent before introduction. Here we are introducing the stent through the femoral artery. This is the stent inside the femoral artery. This is another picture for it. And after we finish the procedure, we just close the femoral artery and the skin. Here, this is a video that I will show to you. As you see here, the guide wires inside the descending and the arch, and we inject the contrast and see here a huge descending thoracic aneurysm, as you see here. The next one, we just introduced the stent, and here this is the pigtail, and we are deploying the stent cell by cell slowly, and during this period the blood pressure should be low to prevent pushing the stent away down. After we deployed the stent, here this is the third video, we still have the proximal part of the stent is captured, and here we unlock the capture. So this is the last step in the deployment, that the stent is fully deployed and cannot move from its place. This is another one, huge aneurysm. Oh, you see that? A very huge descending thoracic aortic aneurysm. Here we put the stent, and you remember that I told you that at the beginning of the presentation, one of the selection cases is the angulation of the descending thoracic aorta. You see here how is the descending thoracic aorta is tortuous, and the angle of the arch is very acute angle. This makes it very difficult to put the stent during the procedure. And here you look to that wire, it goes around the aneurysm till it goes here. This is truly makes it very difficult during the procedure. Here we deployed the first stent, but still we have an endo leak from down because the aneurysm is too long, so we have to put 2 stents. Next, we are injecting to see the second stent, and here we are putting the second stent, and then we do what we call ballooning. In some areas, the overlap between the 2 stents, we have to balloon to coapt well and to prevent endo leak. This type of endo leak is type 3 endo leak between the 2 stents, and we will balloon also the distal end. And after that, we got the final, a good deployment and alignment of the 2 stents and complete disappearance of the aneurysm that we see it before. This is another case. This is a CT scan of a case with type B dissection. Just simple type B dissection. But it starts immediately at the subclavian artery. You can see it here. So we have no landing zone. So that's why this is after deployment of the stent, but we did for that patient a carotid subclavian bypass to make or to create a proximal landing zone. In that video, I will show you the bypass. Oops. Here the bypass will show up here. Yes, this is the bypass. After that, in the follow-up, we did an angio for that patient because he came up to us with a secondary, with still the sac around the stent is full of blood. So we did an angio for him. As you see here, there is a leak around the stent from the subclavian artery. So we did put for him a coil to occlude the subclavian artery, but I will show you something. After this, we did an injection and still there is a leak. You see here, the coil is here. You saw that? The coil is here, but still there is a leak going down to the stent in the descending thoracic aorta. This is why those 2 pictures explain why. Because the subclavian artery is dissected itself, and there is an entry tear in the subclavian artery. So we put the coil here in the mainstream of the subclavian artery, but we didn't occlude the tear here in the subclavian artery. So we put another coil at a higher level, that coil, to occlude the beginning of the tear, and after we inject, so it prevents the secondary leak, the endo leak. And this is another picture. You see that this is the carotid subclavian bypass, and this is the coils that we occluded the subclavian artery at 2 levels, level at the stent and level in the mid artery at the entry tear of the dissection flap in the subclavian artery. This is small videos for you, and I hope that you enjoyed this presentation. Now I can answer some of the questions for the first presentation, and you are welcome to push the questions for the second presentation. About I have a question about the medical treatment, and I answered it in the beginning. There is a question which is repeated many times the intramural hematoma in the arch or penetrating ulcer localized to the arch. This is a very good question. If we have an intramural hematoma or penetrating ulcer in the arch, it is usually not confined to the arch. I never seen that hematoma. I saw penetrating ulcer to the arch also itself, but a penetrating a hematoma localized to the arch itself alone, no. Usually it extends to the ascending aorta or it extends to the descending aorta. Anyway, if we have the acute phase of the intramural hematoma in the arch, we do a CT scan. The patient is not in pain. The hematoma diameter is less than 5 millimeters around the arch, and there is no pleural effusion, no pericardial effusion. This patient can be followed up with medical treatment and to repeat the CT scan immediately after 3 or 4 days to see if this hematoma is increasing or decreasing, the width of the hematoma, if it is increasing more than 5 millimeters, so it's increasing, or if there is a persistent pain that never goes with the analgesics. That's for the acute phase of the intramural hematoma that we can treat medically, but we have to follow up very thoroughly with CT scan after 2, 3, or 4 days maximum. Another question about arch hematoma and the patient is stable. This is what I told you now. But if we have a penetrating ulcer and the patient is stable, but if the penetrating ulcer is more than 20 millimeter in width and 20 millimeter in depth, this patient is not for conservative treatment at all, because this patient may rupture at any time. So we have to intervene either surgically or endovascular. Other question, management of the margin of resection for a penetrating ulcer. In a penetrating ulcer, it is localized. Either we are going to treat it with a stent graft, or we are going to treat it with a surgical intervention. For the surgical intervention, there is no margin because we are treating this part of the aorta with an interposition graft. So there is no margin. Just get a good area of the descending aorta above the ulcer and below the ulcer, maybe 1 centimeter, 2 centimeters, just cut and sew with an interposition graft as it is feasible for you during surgery. من الأسئلة اللي جات لي في من الحاجات اللي قبل كده كان في سؤال: what kind of pleural effusion with intramural hematoma أو penetrating aortic ulcer? Definitely مش هيبقى serous effusion، لأنه لا هيبقى bloody effusion or serosanguinous أو bloody effusion. This effusion that indicates this patient is leaking or rupturing or about to rupture. نيجي لأسئلة تانية. في سؤال بيسأل عن الانتيكواجيليشن في الانتراميرال هيماتوما. There is no need for anticoagulation. عندنا patients we are following these patients either medical treatment or conservative treatment or waiting to do a stent or waiting to do surgery. There is no need for anticoagulation. But if we treated these patients later on with surgery or with the stent, we give anticoagulation, aspirin, for the stent to prevent deposition of platelets or aggregates on the stent itself. This is another question. Other question that how to do the carotid subclavian bypass. There are many types of the bypass. We can do it with one incision in the supraclavicular area that we can do the carotid subclavian bypass, I mean the left side, but this is the most difficult. Usually I do it with 2 incisions, incision in the neck and then incision in the exposing the axillary artery or beginning of the axillary artery and bypassing the graft beneath the clavicle from the neck to the clavicle. And you saw it with the in the video, آخر video that we blocked the subclavian artery. You saw that the corrugated graft coming from the left carotid to the axillary artery. I usually do it like that. Or we can do, if we are going to do bypass for the carotid and the subclavian, we have to do carotid bypass, either pretracheal or retropharyngeal, and then do carotid subclavian bypass. Another question about the subclavian flap. I think this question is not in our presentation, but I will answer it. The subclavian flap, use it in treatment of the carotid, of the coarctation. You just cut the subclavian artery as high as possible before going deep behind the first rib. So we have a length about 4 centimeters from the arch till this cut, and then we take this flap on the descending thoracic aorta as an augmentation of the wall, so we can increase the wall of the coarctated segment. This is how to do the subclavian flap. There is another question, which is a good question: the possible use of femoral artery as an axis if it is dissected. Usually the dissection goes to the either carotid, either iliac arteries, right or left. In 80% or 90% of cases, it stops in the iliac arteries. It doesn't go to the femoral arteries. So we can use either right or left femoral arteries. But if we have a case that the femoral arteries itself is dissected, usually we will find the second one not dissected. But if we have both dissected arteries, this is truly a very difficult situation. As an alternative, we can use both the stents from the ascending aorta, what we call antegrade deployment of the stent graft. I usually do it 1 or 2 times, but it is not the routine. Other thing that we can open the dissected artery and we can choose the true lumen, and then we put the guide wire and follow the guide wire with the IVAS or with the contrast material, that it goes in the true lumen till it reaches to the arch and ascending aorta. And I think the transesophageal echo will be helpful in that, seeing the wire in the true lumen or not in the true lumen. It helps a lot. Usually myself, I never do a dissection case without the help of the transesophageal echo, because really it helps to differentiate between the true and false lumen and where is your guide wire. I hope that I answered most of your questions, and I think the company put the link, and if it is not put on the screen, I think they will give it to you by the WhatsApp, and you will find these presentations on the link. See you in the next webinar. I hope that will be in next 1 month or 2 months, I don't know, but I will prepare a good material for you. Thank you for your attention, and see you, and bye-bye.